Hello friends, we are going to study about otitis media with effusion. It is known as the presence of serous or mucoid fluid inside of the middle ear with no pus. It is also known as secretory otitis media, serous otitis media, mucoid otitis media or glue ear or catarrhal otitis media. The onset is insidious. The fluid inside the middle ear cavity is thick, viscid and sterile, more common in school-going age group of the children. Etiology is due to the malfunctioning of the Stachyon tube, which is most common etiology, in which there is obstruction of Stachyon tube, which mostly occur in the nasopharyngeal end of the Stachyon tube. Then we can appreciate the palatal abnormalities such as cleft palate. Then mucociliary pathology. It may be due to any sort of allergy. Unresolved treatment of otitis media, which may be inadequate treatment or no treatment of the previous otitis media. Viral upper respiratory tract infection, which may be caused by rhinovirus or adenovirus, or increase in the secretory activity of middle ear mucosa. The patient complains with when your patient present to you, it may be with 5 to 8 years old of child, sits on the first bench due to hearing loss, turn TV into the high volume, delayed learning. In small children, the parents may not notice it and may go untreated, and which later causes acute suppurative otitis media or acute otitis media, which gives the symptoms of otalgia and bring it into the notice of the parents. Sign at first we can appreciate otoscopy. We see dull, opaque, lusterless tympanic membrane with no light reflex. The tympanic membrane, if it is thin, we can appreciate bubbles. The mobility is restricted, which is seen in Siegel's pneumonization test using Siegel's speculum. In tuning fork test, conductive hearing loss is appreciated, and also adenoid or tonsillar enlargement can be appreciated. Then from this sign and symptoms, we can make a probable diagnosis of otitis media with effusion, unilateral or bilateral, and the differential diagnoses are barotrauma otitis media, otosclerosis, and acute suppurative otitis media before perforation. Now for the confirmation, we do investigations. If the patient is below the age of 5, we do audiometry, that is play audiometry, and if the child is above the age of 5, we do pure tone audiometry. In this, they show conductive hearing loss, which is between 20 to 40 decibels. It is never more than 40 decibels. Tympanometry shows flat curve. X-ray soft tissue of nasopharynx lateral view may show adenoid hypertrophy. Then for the treatment, we should notice if there is present upper respiratory tract infection or Stachyon tube edema. If it is not present, then we can treat the patient with general measures, else medical treatment for 1 week and general measure is preferred. Then we come to general measures. What is general measures? In this case is frequent Valsalva maneuver, Stachyon tube catheterization, chewing of the chewing gum, and it is done for the 3 months, because otitis media with effusion subsides in 3 months. But if persist, then check for the following criteria, and if criteria meets, we can do myringotomy with gourmet incision, and the criteria is effusion for more than 3 months in bilateral case, effusion for more than 6 months in unilateral case, hearing loss more than 25 decibels, learning delay, and complications like otic meningitis and impending cholesteatoma. Then we have the sequelae of otitis media with effusion. We can study with the mnemonic scar coat. The sequelae are cholesteatoma, adhesive otitis media, retraction pocket, cholesterol granuloma, ossicular necrosis, atrophy of tympanic membrane, and tympanosclerosis. Thank you.